He started as an optometrist at QUT, like most of us here, and he has then gone and done medicine, and so he currently works at the PA Hospital, and also for Vision for Life in Hervey Bay, Meiklejohn, and Loganholme. And his area is glaucoma, surgical and medical, which means that he'll be doing trabs and tubes and MIGs and eye stents as well. So I'll pass the mic over to Braden. We might ask maybe no screenshots or videos of the photos or cases that we have, because we probably still need to ensure that we have consent to share those. So Belinda's just put in the chat the Q&As, and we'll go through those at the end. And if you have any questions throughout the whole presentation, please type them into the chat box as you think of them, and then Braden's very happy to answer them at the end.
Great. Can everyone hear me okay? Yeah, awesome. So yeah, first of all, thank you very much, everyone, for giving up an hour of your evening on a Wednesday, and a big thank you to Joanna and Belinda for organising these nights, especially from the technology side of things, so we can concentrate on the talking. A lot of repeating Joanna's intro, but yeah, I'm Braden Meiklejohn. I'm a general ophthalmologist here and glaucoma specialist at Vision for Life Institute. I did all my med school training here in Queensland. I did all my registrar training in the Queensland hospitals, and then I went down to Melbourne to do extra glaucoma subspecialist training at the Royal Victoria Eye and Ear Hospital. And what am I interested in? I'll just see if this is going to click. Yeah, so I'm interested, like most ophthalmologists, in all things cataract, so from refractive challenges all the way through to emergency cataract surgery for cases of acute angle closure. I also do some anterior segment general surgery such as pterygiums and OSSN management. I do all flavors of glaucoma management, so from MIGs, pressor-flows, trabs and tubes. And I work at both the Meiklejohn and Hervey Bay locations for Vision for Life Institute, and hopefully very soon Loganholme, which we've just opened this month, which is very exciting. I work 2 days a week at the Princess Alexandra Hospital. That's where I would find most of my surgical cases of glaucoma, because these patients typically have more severe disease there. So what do I want you to take home from tonight's talk? So hopefully an understanding of how I approach cases where there might not be a straightforward answer, which is often the case in glaucoma. I also hope you pick up some tips about what I think is important to focus on when it comes to managing some tricky cases in the community. I used to be an optometrist myself, studied at QUT, like many of you listening here, and I remember attending CPD nights, always keen to hear about the complex cases, because I think if you can manage the hard stuff, the more routine cases become a lot easier. I think you'll see with glaucoma cases, there's a fair bit of detective work to do on these patients, but thankfully with glaucoma, we often get the luxury of time over a number of consultations to figure out the etiology and the speed of the progression. So please feel free to ask questions at any time. I think Belinda will do her best to watch out for the questions for me. I can't see the chat, but yeah, please jump in. Yeah, so one of the biggest challenges I find in glaucoma is that these patients often have a fair bit of history behind them by the time I meet them. There's plenty of things that have happened that muddy the waters in terms of diagnosis, in terms of what treatments have already been tried. And one of the biggest patient groups that I think fall into that category of diagnostic overlap and diagnostic confusion are the patients with normal tension glaucoma, or NTG. So these patients usually have at least some of these muddying factors to throw around and leave you scratching your head. So I'll start with a few cases labelled as NTG, which may in fact be the correct label, but it's never as clear cut, I think you'll agree. And a lot of these cases are very recent, so haven't completed all the investigations. You might need to tune into future talks to get the final answers about what's actually going on with them. Okay, so yeah, take this patient from the PA hospital, first case tonight. He's deliberately a little complex and confusing to simulate what it's like to work these patients up in a very busy clinic over about 10 to 15 minutes. This was a 68-year-old male, originally from South Korea, seen by me recently in the glaucoma clinic at the PA in the past couple of weeks, and last seen by an ophthalmologist in 2022. So you might call this their 3-year ophthalmology review. He'd thankfully been seen more recently by our in-house optometrist a few months earlier, who was rightly concerned about the progression of visual fields over the last 15 months or so, and he'd been correctly escalated in terms of his topical drops. So he's now on Glaucoma and Simbrinza, so a total of 4 topical agents. And his IOP over the last few years had always been in the low teens. You can see his central acuity is starting to be affected by his field loss right, west, and left. So right eye's pinholing up to 6/18, left eye 6/9. And one thing I want you to note about patients seen in the public setting, such as the PA hospital, is that these patients are likely not to see the same person time in and time out, like in a private setting. So it turns out between 2015 and 2025 that this patient had seen 10 different ophthalmologists, and not one of the ophthalmologists had seen the patient more than once. So everyone is relying on the written notes before them to have any idea of what's going on. But he'd always had an IOP recorded, and it was never above 15. So in terms of trying to piece together a diagnosis or label for the patient, the notes are pretty scant from previous visits. In 2022, we hear our first mention of the word glaucoma, and specifically a query as to whether this could be NTG. And prior to that, the patient had been seen in a retinal clinic for possible retinal vasculitis. So in terms of real time trying to piece together a complex patient, I like to look at the visual fields as a way to visually represent what's happening with them clinically. And you can see over the past 15 months, it certainly seems like something is seriously impacting this patient's vision. So we have the older fields on the right of screen. I'm not sure if you can see my mouse. And we can see that over the last 15 months, the visual field index for the right eye has dropped from 35% down to 11. And there's also about a 10% drop for the left eye. So what's going on here in terms of etiology? We have some notes saying NTG and other reports of a probably inactive retinal vasculitis, which according to the patient was present back in 2013. I was struggling to get details out of the patient in terms of what exactly happened back in 2013, but it sounded as if a private ophthalmologist was treating him for a potential infection before starting steroids, which I now think was a TB infection. So maybe this might be a case of TB-related retinal vasculitis, but it's hard to see any of this in the medical record. And so when history taking isn't helping me, I often just jump to looking at the eyes in front of me to see if I can get some clues about what's going on. So let's look at his Optos fundus photos. Feel free to comment in the chat any signs you think you can see. I should start by saying that he had a normal anterior segment. He was phakic and no signs of anterior segment inflammation or secondary glaucoma. Yeah, so I think the most obvious finding you can see here is just some quite obvious retinal venous sheathing and really severe attenuation of his retinal arteries and arterioles. He's also got these hypertrophic RPE changes with these jet black clumps or spicules. And these tell me that the retina has been quite stressed over some time for these changes to happen. And you can also notice that just overall, the retina looks extremely atrophic because you're getting a very clear view of the underlying choroidal vasculature. There's none of that typical sheen you get from the RNFL when it's a healthy retina. And I'll just show you the left eye. Again, similarly, you can see the venous sheathing and attenuated arteries. So on a fundus autofluorescence, here you can see the standard background grey glow, which you get from the lipofuscin present in healthy RPE cells. but you also get these areas of hyperautofluorescence from stressed RPE. So for this patient, you can really note that along the inferior arcades, and you'll also notice lots of dark patchy areas. That represents parts where the RPE have died and no longer autofluorescing. And looking closely at the optic nerve, so looking at the right optic nerve, you can really notice significant cupping. You could definitely convince me that this looks glaucomatous with a large vertical cup to disc ratio and what looks like almost complete loss of the inferior neuroretinal rim. Clinically, I also thought there was some pallor to the disc, not just the cup, and there's quite significant cupping also on the left eye. And I also managed to track down the only fluorescein angiogram that he had on record. It was back in 2016, and I think it does show some signs of active vasculitis at the time. So most of the lighter patchy areas here of hyperfluorescence are actually window defects where the overlying RPE is missing. So RPE will normally block the fluorescein, and so now we're seeing the fluorescein that's in the underlying choroid. And you can see those patchy areas mostly along the inferior arcades of both eyes. But if you look closely in the right fundus temporally in this vein here, you'll see like a feathery or just indistinct area of hyperfluorescence. So that's a mixture of vascular wall staining and a small amount of leakage. So that tells me that there's a little bit of activity in the vasculitis at that time. I've included his OCT maculars here as well. You can see they seem to be of fairly normal thickness. He does have some mild epiretinal membrane, and you can see a few patches of outer retinal atrophy, which might be contributing to his reduced visual acuity. And they're pretty similar between the eyes.
Would you repeat the angiogram?
Yeah, well, that's definitely part of the management we'll get to.
Oh, great.
Yeah, so the patient tells me he was originally treated back in 2013, 2014 for some months with oral prednisone, but this gave him severe gastritis. And then I saw a note from rheumatology at the PA hospital in 2016 where he reported he'd self-ceased his new immunosuppressant, well, at the time was methotrexate. And again, that was giving him terrible abdominal pains. And rheumatology made a point of saying to ophthalmology that he could stay off the methotrexate unless we thought he had signs of active vasculitis. So he actually remained off the methotrexate, and eventually rheumatology discharged him from their care when he wasn't hearing much from ophthalmology. So now we have a patient who is off any treatment for their retinal vasculitis, and he's having a number of follow-ups in the retinal clinics at the PA hospital between 2017 and 2022. And at all of these reviews, the patient is described as stable. But I think in some ways we're flying a bit in the dark here because there's no imaging taking place besides an OCT macula. So we don't have any optos, no RNFL, no fluorescein angiography, and no visual field tests. So I would say this is more of a byproduct of a very busy public healthcare system because the clinics are very busy with very little time to review the patient and even less resources to order the imaging you're after. We have the first mention of a cup to disc ratio. It took all the way to 2021 to have that mentioned, and it was listed as being 0.9 cups bilaterally. And then in 2022, we have our first RNFL recorded and a visual fields test. So here's the RNFL. For the cases of normal tension glaucoma, I'm very interested in any RNFL scans I can get my hands on. So this was the most recent one, and you can say for the right eye that it seems to match the visual fields quite well. You've got very extreme thinning inferiorly all the way down to the floor, as well as significant superior RNFL loss, and that could definitely be fitting a glaucomatous type picture. And similarly in the left eye, you can see superior RNFL loss matching the inferior field loss, and there's a bit of mild inferior RNFL thinning matching the early field loss superiorly. And what I love about the Heidelberg RNFL is that it will always plot the baseline RNFL as that grey line behind the black line. You can see a little bit of a gap there. But you can see for both eyes, there's really been no worsening since 2022 whatsoever. And so just to fill in a few more of the puzzle pieces for you. I had to go to a completely different part of the electronic record to see that there had been a glaucoma progression analysis performed, which happened to capture some fields I didn't even know existed for this patient. So now we actually have access to fields going all the way back to 2013. And you can see on the GPA plot that there's these cluster of readings proving that the fields were quite good, with a VFLI of around 90% back in 2013. And then we have this 7-year or so gap where the visual field index drops from 90 down to 40, and a similar but less severe change on the left. So what do you think might have caused the progression over that time? I think we have a lot of information now, so we can start formulating a few hypotheses. So is this potentially all a retinal cause of visual field loss? I.e., is this all the result of his previously treated retinal vasculitis, for which he's now been off treatment for about 9 years? And that's a hard one to answer because he's never seemed to have any great signs of activity clinically. And unfortunately, his last fluorescein angiogram was 2016, and he's been off treatment for such a long time now. So it's really hard to pin down. Could this be a case of an optic neuropathy that isn't glaucoma, such as compressive lesion or nutritional deficiency? I did mention the disc looked a bit pale, which can happen in both end-stage glaucoma or another type of optic neuropathy, but it's something to consider. And what would help narrow this down is if we actually had some test results that we don't have for this patient, and that's optic nerve function testing. So a pupil exam, Ishihara plates, brilliance and saturation scores. If any of these are abnormal, we start thinking more of the non-glaucomatous optic neuropathies. And in this case, just remember we have what we think is a pattern of RNFL loss, which matches glaucoma better. So this patient has preferential loss of their superior and inferior RNFL. So it pushes the case more into being in the glaucoma pigeonhole, I think. Or could this be due to one of the more common risk factors associated with NTG? The commonest one, I think, seems to be undiagnosed obstructive sleep apnea, or OSA. I asked this patient about his sleep, and he did say that his ex-wife said that he snored and that he'd never had a sleep study. But more recently, he said his sleep pattern was a bit different. He said he was only sleeping 3 to 4 hours a night. So that's fitting more with insomnia rather than OSA. Or could he have undiagnosed nocturnal hypotension or overtreated hypertension? Some patients are actually taking their blood pressure medication at night for no specific reason. So it's important to ask patients that are on blood pressure medication what time they take it. And if there's concern about nocturnal hypertension, that could be one reason to keep your patients off a topical beta blocker like timolol that you'd find in Zalacom or Ganfort. Unfortunately, our patient didn't fit any of that. And the next risk factor to consider is vascular dysregulation. So we often find that in NTG patients, specifically, you can have vascular dysregulation in the brain in the form of migraine, or in the peripheral circulation with Raynaud's phenomenon, where they have this vasospastic reaction to cold conditions in their fingertips. So it's thought that the same type of vascular dysregulation affects the optic nerve, and that can lead to greater susceptibility of glaucomatous progression. Unfortunately, our patient denied any of the vascular symptoms as well. And finally, could this be a previously undocumented or missed high IOP? The scenario I'm imagining would be if this patient was a steroid responder. We know that he was on oral prednisone for some time at the start of his vasculitis treatment. And it was around this time that his fields were found to be progressing. So maybe there was like a 6 or 12-month period where he had really high IOPs that were due to steroids, and we just didn't capture it with our eye exams. So yeah, there's lots of things we could do to investigate this further, but I think a few simple things would be important to do for this patient. So he needs a new fluorescein angiogram to check the status of his vasculitis. And I think he could have a sleep study as well to exclude OSA, even though it seems less likely on that more recent history. And we should continue to treat his IOP to keep it as low as possible, because we know this is the main way we can slow down progression in NTG patients. And we also should consider an MRI brain and orbits if the above investigations are normal, or if he continues to get worse despite us lowering his IOP. And what can you take away from this case from an optometrist perspective? Well, I think you should consider that NTG is rarely straightforward and it requires a lot of detective work, very similar to neuro-ophthalmology or uveitis. And it's just so important to try and get whatever you can get documented when you first meet a complex patient. Things like a baseline OCT, macular and RNFL, visual field, Ishihara's pupils. Please don't assume the ophthalmologist has been doing these tests, even though they probably should. Something as simple as recording a baseline cup to disc ratio can be very helpful. And I know you always do that. And also, if you have someone with retinal disease, you don't have to exclude them from doing the glaucoma investigations, such as field tests or OCT RNFL. It's very useful to document these. And you don't have to stop at just one diagnosis. There can be multiple overlapping ones, and one diagnosis can mimic the other. So that's pretty complex, big first case to start with. The other cases aren't as big. The second case, we've got a 56-year-old male. He was referred by his local optometrist over concerns of progressing open-angle glaucoma. And this was on a background of him having known head trauma and a presumed pre-existing left-sided homonymous hemianopia from that head trauma. The patient was quite vague on the history of what actually happened, but he said in 1995 he had a single vehicle motorbike accident where he wasn't wearing a helmet and it left him with patchy vision. It sounded like a severe concussion with memory loss around the incident, so he couldn't tell me what was done in terms of investigations, such as did he have a head scan, but he did say he didn't require any surgery on it. He also said that ever since he's noticed his left side of his left eye's vision wasn't as good, but he'd never had any formal visual field testing done until this year. So we aren't completely sure of his trauma history, but it does seem on his visual field test that he does have a left-sided homonymous hemianopia. And it's a little incongruent, but it does respect the vertical midline. He has excellent unaided acuity in each eye, and his IOPs are quite low, sitting around 12, and he has excellent general health with no regular medications. So here's a better view of his fields. Clinically, his anterior segment was unremarkable. He had just very mild nuclear sclerosis in his lenses and no signs of secondary glaucoma, and his angles were open to ciliary body band, 360 degrees on gonioscopy. We'll have a look at his optos now. His fundus was very healthy in each eye. If you see anything there, it's just artifact. But I'd be very interested to hear your opinion on his discs. And what do you think about his CD ratio? It's really hard to tell on a flat photo, but it's probably not far off where you see the pallor of the cup there. So I've got it as about 0.4 on the right and 0.5 on the left. But I definitely thought his discs had significant pallor bilaterally. And his RNFL is very interesting. So looking at his right eye, you can see significant inferior thinning, but also a little bit superiorly. I would say this could definitely fit with typical glaucomatous damage, but it doesn't really gel that well with his lack of cupping on this side. I think the cupping you see on the infrared photo here is just a little bit worse than what it was in real life. In 3D, it didn't look as big. And when we look at the left eye RNFL, it's almost like an inverse situation. You have all this nasal and temporal thinning, but superiorly and inferiorly, it looks quite healthy. So if you just gave me this RNFL in an isolated situation, I could say that this could fit with maybe a non-glaucomatous optic neuropathy. So with this patient's history, I'd be thinking, could this be a traumatic optic neuropathy from the previous head injury? Comparing them side by side, you can definitely see how they look very different to each other. It looks very unusual. So just some other information I can give you. His CCT was normal in each eye. Ishihara's were full in each eye, and that would be less likely to happen if it was a direct traumatic optic neuropathy in the left eye. But what we really need to know is, does the left eye have an RAPD or any reduction in optic nerve function tests such as reduced brilliance or red saturation. So that's something that I still need to test for and measure. And it's not uncommon that you forget something important. You just have to make sure you do it at the next visit. In terms of normal tension glaucoma risk factors, he had no migraine, Raynaud's, or hypertension history. And in terms of OSA risk factors, he said he's always tired, but he's also a shift worker and they'll always struggle with sleep. He said he is known to snore after alcohol. And just on the topic of alcohol, and as part of questions you should always ask when assessing for an optic neuropathy, this patient had quite a significant drinking history. So he stated he was drinking on average 15 standard drinks a day in the form of wine or premixes over a period of 15 years. So that could definitely contribute in some people to a toxic optic neuropathy. And the other thing to consider, things that go with alcohol dependence, is really poor nutrition that leads to vitamin deficiencies such as in thiamine or folate. But I did clarify with him that this period of time finished at least 10 years before I was meeting him. So I wasn't planning on investigating this. And so now we have a few new potential causes to consider, such as, is this a toxic or nutritional optic neuropathy, possibly undiagnosed obstructive sleep apnea contributing to an NTG type picture, or are we finally just documenting homonymous hemianopia from head trauma that was never previously fully investigated? And how am I going to investigate this myself? So I thought it would be reasonable to get this patient an MRI brain and orbits with contrast to try and identify if there's any structural damage to the visual pathway that might explain a homonymous hemianopia. I'm not sure if we'll find something this far down the track, but I think there might be some like gliosis or cerebral scar tissue to indicate where a previous bleed was or trauma occurred. And it also might identify if there's any atrophy of the optic nerves, especially given that they're pale on examination. I'm also going to ask his GP to do a sleep study, given that he's falling into the NDG phenotype of normal pressures, but suspicious looking RNFL changes, especially in that right eye. So I don't want to miss any treatable causes that could be contributing to the situation. And I haven't decided if I'm going to lower the IOP at this stage because I don't have any evidence of progression. We're still in the investigation phase, but if after, say, 6 months I see progression on either RNFL or visual fields, I'm going to, of course, aim to lower the IOP lower than what it is. So that's the second case. And just a very quick third case while we're on the topic of homonymous hemianopias. What does everyone think of this visual field test, especially if you just look at the pattern deviation down the bottom? I'll show it bigger on the next slide, but this was the test of an 83-year-old lady referred by her local optometrist due to mild to moderate PCO after cataract surgery a couple of years earlier. So I met her at the time of the YAG capsulotomy. She'd already seen a colleague of mine prior to that. And it was noted in the chart that the patient's husband had decided that she shouldn't be driving anymore because she apparently was, quote, not doing it right. And I think that's the reason that they went for the visual field test to be done. She had otherwise reasonable visual acuity, IOPs weren't elevated, and the PCO was fairly benign in appearance. It didn't look very asymmetrical over the visual axis, or nothing that would look like it can give you that sort of visual field result. She did have some hypertension, but was otherwise well. The RNFL, you can see it's a little asymmetric superiorly, just in terms of thickness in that area there, but otherwise it's healthy all the way around. I don't have an Optos photo to show you of the discs, but I can assure you they looked very normal and healthy. I didn't get any suggestion of tilting or an irregular lumpy contour like you might suggest from the OCT, so nothing that I thought was optic disc drusen. And that's the visual field test in large. I think it was pretty reasonable reliability, not many false positives. It's not that congruous, but I think it's very reasonable to label it as a left homonymous hemianopia. So this patient was referred by my colleague for an MRI, brain and orbits with contrast, which is something that I'd also do and recommend. And the results came in. There was some minor age-related changes and small vessel disease noted, but overall nothing that stood out as a cause for these field results. And so the fields were repeated almost a year later after the YAG capsulotomy had been performed. And you can see on the bottom row, there's still like a homonymous finding on the left side. But I'm just wondering if this like second more severe field in the top right-hand corner, I'm just wondering, are we possibly catching an event like a TIA where the patient's having severe field loss at the time, but it's reversible when you go to check it at another time? Like, I'm not sure if we'll ever know, but I just thought it was interesting to share with you. Moving on to case 4. So this is a case of NTG with an interesting feature of pretty distinct asymmetry between the eyes and a few interesting risk factors. This was a 48-year-old male returning for a 6-month review of right eye NTG, and the left eye was also being treated, but it was only a NTG suspect. I hadn't seen the patient before, but his baseline IOP was apparently 18 in the right, 12 on the left. So definitely some asymmetry in the baseline IOP. He was on Xalatan in both eyes at night, and his visual acuity was really good, 6.6 in each eye, and his current IOP was right eye 12, left eye 9. And as it was a review patient from a previous ophthalmologist, this was just my starting point for getting to know the patient and understand what was going on. So I'll start by showing you his visual fields enlarged. So you can see there's pretty stark asymmetry between the eyes. There's quite dense superior arcuate loss in the right eye and a completely normal visual field on the left. This is OCT RNFL. You can see the fields do seem to match the RNFL loss well. You get a sense that there's been almost complete loss of the inferior neuroretinal rim in the right, and that's where the RNFL is the thinnest. And on the left eye, you have a healthy RNFL the whole way around. And so clinically, I go to look at the patient, and the first thing I see are these LASIK flaps. I don't know if you can see the outline there, and these little epithelial islands, epithelial ingrowth. So he tells me he used to be short-sighted before 2009, but he couldn't tell me how myopic he used to be. He has a family history of glaucoma with his mother and maternal grandfather. And I also note that he was like quite a solidly built man. I was just asking him more about his general health, and in terms of other history, he just said he had high cholesterol, but that was about it. But then he also added that he'd also recently lost 65 kilos. He used to weigh 195 kilos, but then he had weight loss surgery. He wasn't exactly sure of which surgery it was, but it's always useful if you can try and tease out if it was a bypass procedure rather than a restrictive procedure, such as a sleeve gastrectomy. The bypass procedures have been known to cause significant vitamin deficiencies to the point where they can cause optic neuropathies. In terms of more history, in terms of sleep apnea, he said he was already diagnosed and he was on CPAP. And he'd also mentioned he'd had a previous MRI of his brain with the last specialist. And that's the results here. There's nothing of significance. So now we have an asymmetric normal tension glaucoma patient with these possible reasons why he might have developed it. So I'll go through some hypotheses. So is this just standard open angle glaucoma with a never recorded high OP, possibly due to underestimation with his thinner corneas post LASIK? That would also fit with his family history of glaucoma. Or could he have quite a structurally different optic nerve? Say one is more tilted than the other. Say if his myopia was greater in his right eye before the LASIK. And that's where it'd be useful to have biometry to see if there's any significant difference in axial length. Or has he had an episode of asymmetric high IOP in the right eye that we've missed? So we know when a LASIK flap is made that the IOP goes up very high during the suction phase, I think up over 100 millimeters of mercury. So maybe there was some asymmetry with that procedure and how long things took on the right eye, or maybe there was another pressure spike that we've missed at another time. Or is this just normal tension glaucoma secondary to severe OSA? Because we don't actually know how long it was left untreated for. We also have someone who's had weight loss surgery. Have they suffered a nutritional deficiency causing an optic neuropathy? I think it's pretty safe to say that's very unlikely in the case of asymmetric glaucoma. And it's really useful to know in his case that he's undergone some neuroimaging because this will help exclude unilateral causes of an optic neuropathy, such as compressive lesion or other optic nerve conditions such as optic neuritis. All right, so asymmetry of IOP between glaucomatous eyes is more commonly the rule rather than the exception. I think it's something like 10% of normal eyes will have a difference of 3 millimeters of mercury between the eyes, but up to 60% of glaucoma eyes or glaucomatous eyes will have a difference of 3 millimeters of mercury or more between them. And that's certainly the case in this patient here. But I did go looking for some of the more unique causes of asymmetric field loss in glaucoma. I thought this was interesting. This is a study out of South Korea, which looked at the preferred sleeping position for someone with either NTG or just regular high tension glaucoma to see if that had any influence on the asymmetry of their field loss. The generalized finding, which was statistically significant for both NTG and high tension glaucoma, was that the sleeping position did tend to affect field loss, and it was whichever side that they slept on. So if they had their left face down on the pillow, it would be the left eye that had the worst field loss. So I didn't ask this patient what his preferred sleeping position was, but now I'd be interested to know if it was his right side down on the pillow. And prior to weight loss surgery, maybe he had extra cushioning of fat around that eye, and it might have influenced the pressure even more. So I just thought it was interesting. And another important topic we've just been seeing the last few cases repeatedly would be when should we expect neuroimaging to be done in these patients when you refer them for possible NTG? So I wanted to go through a few reasons as to what would make me image someone. So I think anyone less than 50 years old being worked up for NTG deserves to have their brain and orbits imaged because these patients are more likely to have robust perfusion to their optic disc. So the presumed mechanism as to why people develop NTG makes less sense in these patients. So I think they should be imaged. I also think anyone with field results that are pretty atypical for glaucoma, those field results that don't respect the horizontal midline, or those that are clearly suspicious for visual pathway lesions such as a bitemporal or homonymous loss or unilateral disease. Also, anyone with orbital signs, so if they show proptosis or chemosis, or lid retraction or ptosis, or any deficit in their motility, they should get a scan. Anyone with symptoms of a mass lesion in their head in general, so if they have severe headaches or symptoms of raised ICP like nausea and vomiting, anyone with seizures or changes in behavior, or if they have optic nerve signs of compression, so pale disc, RAPD, or optociliary shunt vessels, they should score a scan as well. And if their central visual acuity or their color vision is off in the presence of optic nerve changes, that is not typical of glaucoma, so they should have a scan to exclude compression or optic neuritis. And also if the fields continue to progress despite the IOP being adequately lowered, I would image these patients as well. You also may have noticed another recurring theme throughout the NTG cases, and that's been obstructive sleep apnea. So I just wanted to go over specifically how I screen for it for deciding if someone should undergo a formal sleep study. So OSA is the domain of the respiratory physician. That's the branch of medicine that looks into sleep disorders like OSA, narcolepsy, and restless legs. And because OSA affects so many bodily systems, I think it's important that we get the patient's GP to refer for a sleep study, because if that patient's found to have severe OSA, I think it's the GP that needs to be in charge of subsequent referrals. So I think it's fair of you to ask a GP to order a sleep study if you suspect the patient may have OSA, just based on history, or if they have obvious eye signs like floppy eyelids or NTG. So I start off with very basic questioning because some people are very aware of their situation. So I'd start with something very obvious like, do you know if you have sleep apnea? And then if they say yes, just confirm they've started treatment for it. Then I ask if they've ever had a sleep study. If they've had a recent one and it's ruled out OSA, that's probably the end of the questioning there. Otherwise, I start probing them on if they know if they snore or if they have someone next to them that could tell them if they snore, because someone with undiagnosed OSA typically won't be aware of their snoring habits without someone telling them. And then the rest of the questions you can get from both the official screening questionnaire called Stop Bang on the left-hand side of the screen. So other questions you might include would be, do you have high blood pressure? And I also like to ask them general sleepiness questions, like you might find on that list on the right-hand side of the screen. That's the Epworth Sleepiness Score questions. So I often ask patients if do they ever find themselves nodding off in their early evenings while watching TV, or if they were to be left in a dark room like a cinema, is that a situation where they're more likely to fall asleep? And also pay attention to the person in front of you and how they look. So are they a male over the age of 50 with a thick neck and a large BMI? Because they really need a sleep study. And of course, always got to be on the lookout for any eye-specific associations with OSA. So things like floppy lids, normal tension glaucoma, IIH, or if they've had a vascular event like a retinal vein occlusion or non-arteritic anterior ischemic optic neuropathy, they're all really relevant. And so what happens when you've got patients with a positive sleep study for OSA? So they'll get referred and they'll get fitted for their positive pressure airway mask or CPAP therapy. And that has benefits over the whole body, but in general, it makes you live longer and reduces your chance of dying from all sorts of conditions like heart disease and stroke. It gives you much better productivity and mood. Although there's no published evidence to back this up, I've certainly seen a few cases, and I'll share them with you now, of just some visual field test improvement in performance. So this first case is pretty subtle, but we're looking at a left eye of a patient with a superior RNFL thinning and infranasal field loss. So just fast forward a few months after starting some CPAP, and I think you can see there's a little bit of improvement, maybe more noticeable on the grey scale. But the next case is much more dramatic, and I can assure you this was the baseline. Like this baseline was repeatable. They had a few goes at it, but then they started their CPAP for a few months this year, and then it turned into this sort of picture, which I think is pretty impressive. But I think I would say this is just due to a better concentration rather than anything at the optic nerve or brain level. But I'm certainly now on the lookout for any patients that I could do a case series on showing that CPAP improves visual field results. So yeah, speaking of sleepiness, I'm sure you're all at risk of slipping into a coma after listening for the last 40 minutes or so. So I just thought I'd show you a massive wake-up call I got during cataract surgery last month. You might notice this is a typical glaucoma patient's conjunctiva because they've been on my least favorite combination of eye drops, Ganford and Simbrinza, to make them as injected as possible. And you can just see that if I just barely touch them, but they want to bleed like crazy, like that. So I was also aware of how atrophic this patient's iris looked. And soon you'll see me go to start the capsular rhexis, and I sort of do a double take before I think better of it. And I decide to put a Meiklejohn ring in to help me if the pupil decides to come down. And you might wonder, why does it look like an earthquake under the microscope? So I was moving all over the place. Most of those movements was actually the patient moving their legs. So this patient had restless legs, and they'd actually drifted off for a micro sleep. And you'll see when I go to put in the Meiklejohn ring that they suddenly jolt awake. And it gave me a heart attack. There you go. I think I show you a small replay just to relive the moment. So I asked the patient what happened, and he said he was dreaming and he thought he was running around an athletics track, which I didn't think was very helpful for the surgery. So I decided the best thing to do was just to get the cataract out as fast as possible because I still had to decide if he would be safe enough to insert a hydrous stent. So I had a chat with the patient. He said he could stay awake and stay with me for about a minute or so. So that gave me enough of a window. So I got my view. I can see the red line that represents all the blood refluxing from Schlem's canal into the trabecular meshwork. And luckily the hydrous insertion went smoothly. And you can see at the end of the case that I think the Meiklejohn ring was a pretty good call because the pupils come down quite a lot. And you also might notice he's got a pretty unique looking cornea because he'd had a previous radial keratotomy, and they're pretty rare to find these days. So that was some fun for me. And then we'll go to the final case. So This is going to the other end of the spectrum here in terms of IOP. So we're now dealing with a very hypertensive eye. This was a 55-year-old female. She was referred to me by a colleague for a second opinion on management. She'd been managed as an open-angle glaucoma case for many years. I think she'd been seeing my colleague for only a couple of years, but she'd been seeing specialists on and off for about 30. She'd had some SLT with some response in 2023. She was a high myope of about -8 diopters. And she was also starting to develop some early cataract. You can see she's got a bit of refractive shift with reduced aided visual acuity of 6 on 12 in each eye, but it pinholes up to 6 on 7.5. And her IOPs were quite elevated at around 50 in each eye on Goldman applanation tonometry. And she's already been escalated in topical drops to be on 4 agents, and this has happened steadily over the preceding 18 months as her IOP proceeded to climb. So she's on Zalacom and Simbrinza, and she had a fairly normal CCT, I guess a little thicker in the left eye. So when I see a case like that or like this, I'm immediately interested in what stage of glaucoma the patient is in, because that'll determine how aggressively and how quickly the patient needs to be treated. So if I see IOPs of 50 in someone who's at the severe end of the disease, you might find that they just need their surgery immediately within a couple of days or so. But if they're at the early stage of the disease, you often have a bit more time. So this patient, you can see, has visual fields with quite a bit of generalized reduction in sensitivity, but without any pattern loss. They have a mean deviation of between about -5 and -8. And so you still need to piece together how much cataract they have and if there's any RNFL thinning to truly figure out what stage of glaucoma they're at. But it seems to be quite mild at this stage. So we can see on their RNFL of the right eye, there might be some mild thinning supranasally in this area, not much. And then a little bit of an inferior dip here, but otherwise it's just reasonably healthy, especially in a myope where you've already got the RNFL probably thinner already because it's stretched out. And you can also note with the Heidelberg, again, we've got that grey line representing the baseline behind the black current scan. And you can see it's been very stable over the last 18 months. And so the same on the left eye, very similar, hasn't changed from baseline, and overall reasonably healthy. And just matching the optic disc photos to the RNFL, you can see moderate cupping without any extreme neuroretinal rim thinning. So it's suspicious for early to moderate glaucoma, but I wouldn't say advanced. And so now we've established we have a patient with quite extreme ocular hypertension, but at the mild or early stage of their glaucomatous damage. And looking back through the chart, it seems that the patient had pressures of, say, high 20s or early 30s for the past 2 years without any definite signs of glaucoma progression at that level. So I think we're dealing with someone with at least a moderately resilient optic nerve, and the IOP rise appears to have been gradual, given that we don't have any pain or corneal edema, like signs that there's been an acute IOP rise. And so next we can look at the patient clinically, and I wonder if you can make out any of the subtle signs in the anterior segment photograph. It's always so hard looking at just a photograph off the bat, trying to figure out what's real and what's artifact. But I'll tell you that the patient is phakic with mild to moderate cataract. This little funny greenish thing is artifact. But I think the big clue or big giveaway sign is that I'm just trying to deliberately get a small beam of light straight through the pupil. So with that in mind, you might be able to make out just some subtle iris transillumination defects there. And they were really faint. So we tried to take a photo on the anterior segment camera and it just didn't show up. So this is actually holding an iPhone up to the oculars. That's the only thing sensitive enough to capture it. The fellow eye, a bit of a different story. I think it's much more obvious. So you get almost a 360-degree region of transillumination defects. And again, this patient was phakic in this eye with mild to moderate cataract. So my first thought when I saw this patient was it's like a pigment dispersion patient. I thought these defects you could consider slit-like and it all fit with her being myopic. So of course I was very interested to look for these two signs. the densely pigmented trabecular meshwork and a Krukenberg spindle. But you might notice that these photos are from a textbook because our patient definitely did not have these signs. I was very shocked by just the distinct lack of pigment in her angles on gonioscopy. So I can show you her angles, at least on anterior segment OCT. So you can't see the lack of pigment, but you might also be able to notice there's a distinct lack of reversed pupillary block. So you might see that in someone with pigment dispersion syndrome. So these irises here look pretty flat, not bowed one way or the other, whereas in pigment dispersion syndrome, you typically get this sort of configuration where the pupil acts as a one-way valve, letting fluid in to the anterior chamber from behind. And that will lead to pushing the iris backwards onto the zonules, and you get that friction effect that releases all the pigment, and that's what clogs up all the drainage pathways. So reverse pupil block is the typical finding in pigment dispersion syndrome. And it's thought that the increase in regular pupil block, so not reverse pupil block, that happens with the aging lens as it gets thicker over time, is thought to undo some of the reverse pupil block you get in the younger myopes. So that probably explains why the OCT findings look the way they do in our patient. So just to say that again, we all have a tendency as our lens thickens with age to be at risk of regular pupil block. So they're the ones you see in cases of acute angle closure. But when this happens in patients with pigment dispersion, it kind of evens out their initial reverse pupil block. So in terms of pigment dispersion over the long term, I did find some reports that, like say the disease burns out over time because you run out of pigment to disperse, and that these signs, such as the Krukenberg spindle and the pigmented trabecular meshwork, becomes less prominent. And that was certainly the case with our patient because I couldn't see any evidence of the pigment whatsoever. So what was my immediate management for this patient in front of me? I decided to treat it as a case of secondary open-angle glaucoma, probably pigment dispersion syndrome, and I added some oral Diamox to their 4 agents they were already on topically. And we get it back 2 weeks later. The IOP hasn't budged, even with the Diamox. Rechecked the pressure, it was still high in the high 40s. And so clinically at this time, I convinced myself I could see some AC cellular activity. So I was trying to think outside the box, and I thought maybe the reason they had no other signs of pigment dispersion syndrome was because it wasn't a case of that. And I thought, could this be a hypertensive uveitis with herpetic disease as the main cause? Because that can also give you a long-term iris atrophy. So I decided to add topical prednisolone fort 6 times a day, oral Valtrex as well, and I said I'll see you in a week. I also increased the Diamox to 4 times a day, and I wouldn't go over that dosing for glaucoma patients. And I knew that at this point, if the pressures weren't coming down, that it was probably time to operate. So 7 days later, when they came back, that's exactly what needed to happen. The pressures were now 55 in each eye. And I was finally able to track down some old notes, and hopefully you can see that on the right-hand side of the screen, but if you squint, I think these notes from 1996 say pigment dispersion noted in angles, or it could be pigment dispersion not in angles, I'm not sure. And the patient was shipped up to the PA hospital for me to do urgent bilateral pressor flow shunts combined with cataract surgery. And fortunately, it was successful with IOPs down into the teens on day 1, now off all the Diamox and off the topical medication. And then tomorrow, it's all early days. Tomorrow, I'll be seeing her for her 2-week review. I didn't do trabeculectomies in her because she's a very high myope, and there's a really high chance in those patients of inducing hypotony. And that's also why we put little stents up the lumen of the pressor flow in the form of a nylon suture. So hopefully she doesn't run hypotenuse in the early days. So yeah, take-home points from this case. I think it's important for you to be patient and realize that you probably have time to work out the diagnosis over multiple visits. It becomes more urgent as the stage of glaucoma worsens in severity, though. And I thought it was very interesting to note the lack of signs of pigment dispersion in this patient at the age of 55. So I think the signs certainly decrease with time. Yeah, so I hope these cases have been helpful in demonstrating that glaucoma is not meant to be that straightforward all of the time, and sometimes you won't get a definitive answer of what's going on, but that shouldn't stop you from being able to approach the situation with a plan to consider all possibilities and refer the patients for appropriate investigations to rule out the nasty co-pathologies. So happy to answer any questions you have on the cases or glaucoma in general, but otherwise, thank you very much for listening. Thanks for your time. Thanks to my organisers, Belinda and Joanna. Do we have any questions?